Welcome to all the trainees all over the world who have joined us in our YouTube training channel. Today we are reaching the 25th episode in our urology exam preparation. We are going to discuss genitourinary trauma. Today is the first episode. In the first episode, we are going to discuss renal trauma and ureteral trauma. In the second episode, we will discuss bladder, penile, and testicular trauma. I've got an interesting news to share. We have made a kind of arrangement and pact with an international training group. It is known as ITRU. ITRU stands for International Training and Research in Uro-Oncology and Endourology. I'm so fascinated because endourology is my main subspecialty. They used to conduct a lot of international programs in the name of Eurogrip, which stands for Urology Global Residence ITRU Postgraduate Program. They do a lot of webinars. We had a wonderful webinar day before yesterday. Now, because of these arrangements with ITRU, you will be seeing a lot of ITRU and Eurogrip related programs in our YouTube channel, and similarly our training programs will be present in their platform. Our channel is predominantly concentrating in preparing the trainees for the exam, and we mimic exam situations and conduct mock examinations. ITRU conduct lot of international webinars with invited faculty from America, UK, European countries, and of course Asian countries. So this becomes a very nice balance of increasing the knowledge and also the various platforms by which you can test your knowledge also. I'm really looking forward for a much wider collaboration with them. We got a trainee on board. Welcome.
Good morning, Mr. D. And again, thanks for this opportunity. I'm happy for this recording to be shared in social media for the use of trainees for the purpose of future exams. Thank you so much.
Thank you. That's very kind of you. Let's directly go to the scenario. You are an on-call SPR and the emergency room is got a patient who had road traffic accident while riding in a motorbike. He is 35-year-old, otherwise quite fit. He had injury in his right flank. How are you going to evaluate him?
I will consider this as a urological emergency. I will attend the A&E soon and see the patient. My initial concerns will be to go ahead with the ATLS guidelines for the resuscitation. So I'll follow the ABCDE protocol. I'll make sure that the patient is stable. Once the patient is stable, I'll like to know the mechanism of injury and whether he is conscious, whether he can talk, or whether he is incapacitated. This will be followed by a quick examination, which will be here examining his chest, abdomen, flanks, external genitalia, and rectum, depending upon the clinical condition of the patient. I would also like to know whether he is catheterized, or whether, if he is not catheterized, whether he has passed urine and whether there was any visible hematuria. So this will be my initial approach to him when I see him.
Okay, it's a blunt injury on his right flank, and he's conscious and he's riding on his own, so there is no pillion rider. He had initial low blood pressure, but the emergency team is able to resuscitate him. He doesn't require any major resuscitation. There is some evidence of kind of a blood in the urine we observed, and the urine samples were taken and it showed dipstick positive for RBCs, and the samples were also sent for the culture. How are you going to proceed with this examination?
So I'll be concerned with that blood in the urine because that will be an indication to do an imaging. So if there are no other concomitant injuries, I will arrange for a contrast enhanced CT scan of the abdomen and the pelvis and see if there is, because my suspicion here will be right renal injury. So the contrast intensity will give me more details on that one.
Okay, I'll share the pictures now. Okay.
So in this one, I can see an axial section of the CT scan.
Okay, I'll show from the top is axial renal cortical phase. We are starting first. Okay, you can you can talk as we see.
Okay. So as we come down, you can see the liver. You can see the left kidney and the spleen, the right kidney. The most striking abnormality is the collection around the right kidney, and it seems that the hilum is almost completely enclosed with the hematoma. Again, coming down, I can't see anything in the pelvis. I was not able to, I couldn't make any rib fractures or any other concomitant injuries in the CT scan. And the most striking abnormality is a grade, I think this is the grade 5 renal injury, because it seems to be like a shattered kidney. Okay. I can see the contrast in the collecting system, but there is no extravasation of the contrast outside it.
Okay, this is the excretory phase.
Excretory phase. So I can see the contrast in the upper ureter now. So there is no collecting system involvement.
Okay, I'll show you the other sagittal renal excretory reconstruction, and then we can discuss further.
Sure.
Any extra features you can see in sagittal reconstruction?
I can see the hematoma. I mean, it seems to be like a severe parenchymal injury, and a part of the lower pole is, I can see it's a separate one. So that's why I thought it is a shattered kidney.
Okay. So we can go back to the axial renal cortical phase, which is also a contrast one. So what is the difference between the CT scan for, say, renal trauma and renal tumor?
In renal trauma, it's mainly two phase only, the arterial phase and the delayed phase. However, in the tumor CT scan, it is multi-phase, three-phase, the plain CT, the arterial phase, and the delayed phase. So this involves only two phase.
Okay. The slight difference which I differ from you is, for example, this patient is grade 4 injury. In exams, if you classify grade 4 as 5 or 5 as 4, it doesn't make any difference. You should know what are all the gradings and you should be confident in what you're saying. But just for the clarification, if you see, the renal contour is relatively nicely maintained, and I can go from, say, the top pole where we can see the upper pole, mid pole. The renal contour is very well maintained. There is some evidence of PCS involvement possibly. That's why he also had hematuria and perirenal hematoma. So there are some good amount of injuries, but it's not like shattered kidney. You can see that lower pole is maintained, mid pole is maintained. So the overall renal contour is maintained. So at least in one area, it is much more involved. So this is a good example for grade 4. But as I said, labeling grade 4 as grade 5, that's not a very big difference as long as you are confident on the complete staging details. Okay. Good. So how are you going to classify the renal trauma?
The renal trauma is classified according to the AAST, American Association of Surgery for Trauma grading scale. It was updated into 2018. It has got 5 grades. Grade 1 is subcapsular hematoma. Grade 2 is parenchymal laceration less than 1 centimeter. Grade 3 is parenchymal laceration more than 1 centimeter. Grade 4 is collecting system involvement or segmental vessel involvement. And grade 5 is shattered kidney with a renal hilar avulsion.
Okay. In grade 1, 2, 3, there should not be any extravasation of urine. And from grade 4, you can get extravasation of urine. And grade 4 is both laceration through corticomedullary junction into collecting system. That's what we have seen in this patient. Or any vascular injury like segmental renal artery or vein injury, like for example, upper pole, lower pole veins. And grade 5, apart from shattered kidney, it could be also renal pedicle or avulsion injuries, or. So it's not both, could be or. So how are you going to manage this patient?
So for a grade 4 injury, the initial approach to management is conservative management. Because a patient is conscious, I'll tell him that unfortunately this is the injury to the kidney and he needs to be managed conservatively. The initial principles of management are complete bed rest, fluids, painkillers, and monitoring his vitals initially every hourly until it becomes stable. If his hemoglobin falls, then he might need blood transfusion. And if there are any signs of deterioration, then he will go for a repeat imaging. Or if he's remaining stable, a repeat imaging will be taken 48 hours later.
Okay, so your predominant method of dealing him is conservative management if he is hemodynamically stable. Good. What do you mean by massive blood transfusions? Nothing to do with this case. I just want to deviate to tick the boxes on the other small topics which may be discussed. Massive blood transfusion. Do you know what is the definition and how are you going to tackle that?
I think the massive blood transfusion is infusion of need for infusion of red blood cells more than 10 units. I'm not quite sure about it.
Okay, so any patient who is presenting quite unstable with very severe blood loss, we need to start a protocol known as massive blood transfusion protocol. It involves initially transfusing 4 units of RBCs and 2 units of platelet or FPC, fresh frozen plasma. After that, based upon the patient's bloods, you can classify and there is a full protocol by which you can tailor the further transfusions. These are all very important, especially if there is a multi-organ injury and the patient presenting in a hemodynamically very unstable manner. Now, can you just take me through what is your principle in treating renal trauma from, say, grade 1 to grade 5?
So nowadays, most of the renal traumas, irrespective from grade 1 to grade 5, is mainly managed conservatively. Most of the grade 1 to 3 traumas can be continued with the conservative management. And most of the grade 4 trauma also can be managed with the conservative management. Sometimes grade 5 traumas, if the patient is hemodynamically unstable, will have to go for the surgical exploration. So the indications for surgical exploration is mainly hemodynamic instability while the patient is being conservatively managed. There are some signs in the CT scan that can predict the need for further surgical management, which includes extravasation of extravasation of the contrast, medial hematoma, and hemodynamic instability associated with that. So if these features are there, we can predict that. And also, if the patient initially needs 2 units of blood transfusion, that is also considered as a predictive value for the further operative treatment. As long as the patient remains hemodynamically stable, always the principle is to continue with the conservative management. If for any reason, for other concomitant abdominal injuries, the patient is going in for a surgical exploration, then the indications for exploration will be expanding retroperitoneal hematoma or pulsatile retroperitoneal hematoma. And in most of the time, if the patient remains stable, we will continue with the conservative management. But in the ward, if the patient becomes unstable, then the initial intervention will be a radiological intervention in the form of a angiography followed by angioembolization. And also, if the patient remains stable without any hemodynamic instability, a repeat CT scan is warranted after 48 hours to see and review the grade of the injury, and also to see the amount of perinephric hematoma or if there is a collecting system injury. And even the collecting system injury is also initially managed conservatively. The indications for interventions in a urinoma are if there is a huge urinoma collection or if the patient is developing any signs of infection or chance of abscess formation. In those cases of collecting system injury, intervention is warranted. So these will be my principles of approach.
Good. What is the role for ultrasound in a renal trauma patient?
I think nowadays there is not much role for ultrasound. Previously, there was a concept of fast, focused abdominal sonogram for trauma, but because the sensitivity is poor and operator dependent, and also the AST grading is based on CT scan, the CT scan is always preferred over an ultrasound scan, at least in the initial evaluation. So that's what I know about ultrasound scan.
Yes. Apart from this, you can add two things. The first one is a contrast ultrasound, which is a kind of a further developed way of ultrasound. Do you know anything about contrast ultrasound?
Yeah, so microbubbles can be used as contrast for the ultrasound scan, but I haven't read that much only about that. I'm not sure whether it is applicable for the trauma situation. Sorry.
Yeah. It is very useful in trauma situation. Say, for example, you can say even the dose of microbubble, it ranges from 0.3 to 1.2 ml. So it's a very small amount. And as you inject the microbubble, you can see the contrast enhancement within 50 to 60 seconds. So these are all very crucial. So it means patients should be ready. And as we inject, the person should be doing the ultrasound. Contrast enhanced ultrasound is relatively rare. We don't use it that regularly, but in trauma it is very good because the contrast enhancement shows the presence of vascularized renal tissue. So if there is a one pole of the renal tissue which is not uptaken by contrast, that gives you an idea about the presence of any vascular injury, segmental vascular injury, or avulsion of that quarter of the kidneys. The other importance of ultrasound, apart from the initial evaluation, is in the follow-up. So you had a CT scan, you are going to another follow-up imaging in 48 hours. And if the patient is stable, instead of subjecting the patient to further radiation of CT scans, you can follow the hematoma with the help of the ultrasound. Okay? Good. And say, for example, this patient after 24 hours becomes unstable and you need to take the patient to the theater. What precautions you will take? How are you going to approach him?
So it will be a multi-modality approach, and I'll make sure that the patient is resuscitated enough and is remaining stable during the transfer. I'll make sure that enough blood is available, and also if available, the expertise of vascular surgeons is available on board. Also, I'll make sure that the patient is continuing on antibiotics. And for an unstable patient, renal trauma in theater, ready for exploration, the principle is midline approach and early access to the vessels. So for after opening the abdomen, the initial approach is to the anterior part of the aorta so that we can have a control over the renal artery. And once we get the control over the renal artery, we'll go to the lateral part and reflect the colon and then assess the hematoma. So in this situation, as we already know that the left kidney is normal, there is no need for one-shot IVP. But if the patient is going directly to the theater from A&E without any previous imaging, then that will be an indication to do a one-shot IVP. In this patient, if he's becoming unstable, then that probably will. So the initial approach is to remove the whole blood clots from the retroperitoneum with adequate control over the vasculature, and then to see and assess the renal trauma. If any part of the kidney can be salvaged. A partial nephrectomy is an option, but if it is like non-salvageable kidney with lots of devitalized tissue, then even nephrectomy is indicated in that case.
Yes, any surgical exploration usually leads to nephrectomy. That's why nowadays, even for grade 5 trauma, we try not to take the patient for exploration unless there are some features like hemodynamic instability, expanding hematoma, as you said, or if the patient is going to be taken to theater for other concomitant injuries like colon injury or spleen or liver injuries. And the principle is the kidney is very nicely preserved retroperitoneal area. So as long as the main vasculature is preserved and there is no involvement of the pelvic ileal system, the hematoma will be easily resolved from the retroperitoneum. Any involvement of peritoneum only causes peritoneal collection, and it takes a long time for the reabsorption, and also it results in ileus and further slow progression. You mentioned about one-shot IVP. Could you explain this further, please?
So the one-shot IVP is done when we are doubtful about the presence and function of the opposite kidney. So if we are called to see a patient on table without any prior imaging for exploration of retroperitoneal hematoma, a one-shot IVP is recommended. So this is done initially by giving 2 ml per kilogram of contrast. We usually give Omnipaque and taking a X-ray after 10 minutes. So in that X-ray, what we are looking for is the presence of opposite kidney, the function of opposite kidney when we can see the renogram. If the contrast is getting into the pelvic ileal system, then that is a sign that the opposite kidney is present and functioning. So that is the role of, and also sometimes, although the sensitivity is comparatively less compared to a CT scan, we can assess the injury of the ipsilateral kidney. So that is the principle of one-shot IVP.
Yeah. So one-shot IVP is very good in patients who are very unstable and taken to theater directly from the emergency room. And this gives the surgeon a confidence of presence of opposite normal kidney, and that will have good amount of impact in decision making in treating the injured kidney, because by chance if the opposite kidney is absent and if it is also not enlightened by the contrast, then we need to explore the opposite side or to make sure the patient has renal tissue in the post-op period. If the opposite kidney is normal and conservative managements are not helping, the patient lies quite unstable, sometimes anesthetists wish a quick nephrectomy to make sure that further blood loss is prevented. That can be decided easily by one-stop IVP. But in the presence of the CT era, the chances of one-stop IVP is now become more theoretical, but we don't know. There may be one day where we need to take the patient directly to the theater without the CT scans. Okay. So this patient, you have treated him conservatively. In the 48 hours, he got much better. He moved his bowels and is hemodynamically stable. You have arranged a follow-up CT scan or ultrasound. In my practice, ultrasound is enough because you have one CT scan. If the patient is stable, there is no need for further CT scans. And it shows good amount of resolution of perinephric hematoma, and you are planning to discharge the patient. What is your advice on discharge?
So I will advise him strict bed rest for 2 weeks. And then if he develops any pain, fever, or any symptoms, then he has to come back to A&E. And afterwards, he will be followed up for regular follow-up, mainly to review his renal functions. And his blood pressure needs to be checked regularly to see if he develops any renovascular type of hypertension due to the injured kidney. So this will be my approach to him for the follow-up.
What is the mechanism for renovascular hypertension after renal injury?
So it could be either due to a large subcapsular hematoma compressing on the renal parenchyma, which is known as page kidney. Also, it could be due to the vascular compromise as explained in the gold black kidney, the 2-kidney 1-clip model. So these are the principal. I mean, it's either due to the page kidney or the vascular compromise that is resulting in renal vascular hypertension.
Okay. You need to bring the renin-angiotensin mechanism.
Oh, yeah, sure.
Can you explain?
Yeah, so what happens is because of the injury to the kidney, the other kidney will try to compensate it, and the renin-angiotensin, the opposite kidney's renin-angiotensin mechanism will get activated. And the angiotensin is a powerful modulator of blood pressure, and that is one of the reasons for the cause of the renal vascular hypertension.
Yes. So how it works is the renin-angiotensin mechanism, as you may have read in your medical school, it deals with the glomeruli. So whenever there is a page kidney, it creates a kind of an increased pressure, which results in the sensors to decide that there is not much filtration and we need to increase the vascular tone in view to improve the filtration. And once the vascular tone is further increased, it will manifest as hypertension. How are you going to follow up this patient?
Outpatient follow-up, mainly to review. The initial review is to review his hemoglobin level and the urea and electrolytes, and reviewing the blood pressure. Once these are remaining stable, then we will inform the general practitioner to continue monitoring his blood pressure to see if he's developing any renal vascular hypertension.
Okay, that's good. So we will complete the renal trauma at this point. So renal trauma is a good scenario for the emergencies and trauma scenarios. The presentation mainly need to concentrate on initial evaluation. We can spend some more time on the ABCD, stabilizing the patients, etc. But that's quite very common approach, not very specific to urology. And when the CT scans are given, as you mentioned, please mention the opposite kidney to make sure that it's normal. And while grading, take it like this. Grade 1, small contusion, very rare for an examiner to bring to the examination table. Grade 2 and 3 is less than 1 centimeter, more than 1 centimeter. That's very easy to differentiate. Grade 4 and 5 are slightly difficult to differentiate, but grade 5 is like absolutely shattered kidney, and grade 4 means at least renal contour is maintained to a certain extent. Whenever there is hematuria, it should be at least grade 4, because up to grade 3 there is no involvement of pelvic axial system. And those are all the small clues you can have while labeling. Sometime the examiner may say grade 3, but hematuria also in the history. You can even challenge the examiner. If there is involvement of pelvic axial system, it's grade 4. Up to grade 3, there should not be any involvement of the PCS or ureter. And if you are taking the patient to the theater, make sure it's a multimodality and make sure you are having a trauma surgeon with you, or at least a general surgeon, whoever is on call. And you may have to reflect the colon and aim for multiple organ exploration and necessities. Make sure that you are having the landmarks of inferior mesenteric artery and superior mesenteric artery. Many a times, if you have to do emergency surgery, you need to get enough exposure to the vessels and keep a loop on the involved vessel, like right renal artery and vein, and also loop the opposite side renal vein for the sake of control. And then you can mobilize the bowel or reflect the bowel and approach in the retroperitoneal fashion. So all the trauma surgeries are transperitoneal. There is no approach like retroperitoneal only. And mostly the kidneys are salvageable if they are treated conservatively. But if the patient goes to theater, sometime even grade 4, even grade 3 will end up in nephrectomy. So that's why conservative approach is given much more importance, and evidence is now clearly showing up that conservative approach will result in at least salvaging a partially functioning kidney. There is a role for DMSA in the follow-up. So if you do one baseline DMSA in the follow-up, that gives you an idea about the percentage contribution of the traumatic kidney, so that if the patient presents later, we know at least the baseline functions. Okay.
Thank you so much. That's really clear now, the grading and the follow-up. Thank you.
Good. Use the grading to your convenience, and you're confident in grading. That's how it has to be. Good. Let us discuss another scenario. So this is a 45-year-old female undergoing radical hysterectomy with bilateral salpingo-oophorectomy for cervical cancer. Unfortunately, during the surgery, which was done by laparoscope, was quite challenging, prolonged surgery, intra-bleeding requiring transfusion. But somehow the gynecologist are quite happy with the outcome, and patient is in the post-op recovery. She's stable. On the second day in the abdominal drain, they found a serosanguinous fluid discharge appearing like urine. She got catheter in place. So they have called you to examine the patient and help. How are you going to proceed?
So I will see the patient as an urgent one. And my concerns here are whether the patient is stable. If she's unstable, then I'll start the ABC protocol. Then my concerns here are what the approach to surgery to laparoscopy. And I will request the drain fluid to send for a creatinine assessment to confirm that it is urine. And I will approach this in a way that to see her current condition. If she's stable, I will review the records. I will contact the surgeon who has done the procedure if he is available, and request him or her to walk me through the procedure, the difficulties they have encountered, whether there was any, whether they have positively identified the ureter during the procedure, was it difficult to identify the ureter. I will review the operation records. Then I will review her medical history, whether she is fit enough to have a second procedure, other previous surgical histories she had, if she had any previous radiotherapy, what was her urinary symptoms like prior to the procedure. And I will review her bloods, and I will also review her imaging before the surgery to see the presence of the kidneys and if the mass has been encasing the ureter in the previous scans. With all this information, my concern will be a ureteric injury. I will see the patient, explain to her honestly that this is the concern, unfortunately, and this is possibly a non-complication of a difficult surgery, the pelvis, and then now we have to treat this one. So after confirming the fluid creatinine, my next approach will be to arrange for a CT with a delayed contrast phase of the CT scan to see the location of the injury, to confirm the extravasation of the contrast from the ureter, and thus by confirming the ureteric injury. Before that, I had to examine that. I'll examine her with the help of a chaperone, mainly to see how her abdomen is feeling like, whether it is a peritonitic abdomen or if it's only a collection in the localized area only. Also, I will examine her external genitalia and a vaginal examination to see if there is any pooling of the urine in the vaginal orifice, because sometimes the ureteric injury, especially in difficult cases, can be concomitantly associated with a vaginal injury, bladder and vaginal injury, causing a vesicovaginal fistula as well. So my concerns here will be to confirm that it is a isolated ureteric injury and to make sure that there are no other organs or a vesicovaginal fistula is involved in the injury.
Okay. You said to me about sending the drain fluid for creatinine. Could you explain this further?
So I had to send the drain fluid mainly to look for creatinine. So what I'm going to do is to compare the serum creatinine with the drain creatinine. And if it is more than like 5 to 10 times the serum creatinine, then that is suggestive of urine, because in the urine, the creatinine value is around 10 times than that of the serum.
Okay. The other way is you can send the urine sample, the drain sample, and if the urine sample and drain sample creatinine values are matching, that's a very easy way to compare comparatively rather than depending on the blood values. Okay.
Yeah.
Okay. What kind of CT you are going to organize for her?
So for her, I'll delayed phase contrast CT scan, where a scan will be taken 10 minutes after the contrast injection. So I have to delineate the pelvic calyceal system and see the ureter and see if there is an extravasation of the contrast from the ureter.
Okay. Are you able to see the pictures now?
Yeah, I can see the axial face of a CT scan, axial cut section of a CT scan.
Okay.
So coming down, I can see both kidneys, liver, spleen now. So I can see hydronephrosis of the left kidney as it is coming down. So this is a plain CT scan, I believe.
Yes.
Now I can trace the ureter all the way down. That means that there is a ureter, dilatation of ureter as well. And at that point, I can trace the ureter. Yeah. So at that point, I cannot further trace the ureter, and I can see a small collection in that area near to the pelvis. Coming down again, this is the lower part of the pelvis at the level of the umbilicus.
Yeah. The other thing you can see is the drain. You can see the drain kept.
Yeah, there's a drain there.
Okay. Good. So let me show you the different picture now.
Mm-hmm.
Okay.
So this is the delayed phase of the CT scan axial section, and the striking abnormality is again a left hydroureteral nephrosis. I can nicely trace the contrast in the left ureter, which means that the left ureter is dilated, and I can see the contrast extravasating in that area and going into the drain. So
yeah,
in the lower part also.
So the contrast extravasation is predominantly here. The drain is kept there. So drain is not really in the exact pooled area, but there is a tracking of drain, and you can see the fecal loading and flatulent bowel that shows that she is kept on say redundant position, and so she's not opening the flatus comfortably. Okay.
Yeah.
Let us see the coronal reconstruction.
So you can see again the coronal section where there is a complete cutoff of the contrast in the left ureter, mostly in the comes to the almost to the lower third of the ureter.
Yeah,
I can see the contrast in the bladder from the opposite draining from the opposite kidney.
Yeah.
So I think it will be like 4 to 5 centimeter above from the level of the bladder. The bladder is collapsed.
Okay. So fortunately, the radiologists are interested and created this 3D rendering image.
Mm-hmm. So this shows that we can trace the ureter up to the level of the pelvic brim, and then there is a collection of the urine around that. So I would assume that it is, and I can see the drain as well.
Yeah.
So it is a injury to the ureter at the level of the pelvic brim, possibly a a transaction because of the extravasation of the urine.
Okay. So what are all the various reasons ureter can be injured for a female patient who is undergoing radical hysterectomy with bilateral salpingo-oophorectomy? What are all the reasons?
So the most important reason is a difficult surgery, especially when it is done for a oncological purpose. The surgeons need a very good clearance margin. So and also difficulty in positively identifying the ureter during the surgery. The other reasons for ureteric injuries are indications when the surgery is done for benign conditions like uterine fibromas, and also during, it's very unlikely to happen during cesarean sections. So it's mostly because of the difficult surgeries.
Okay.
And
So the injury can happen like inadvertently by the usage of the harmonic scalpel or any diathermy, or during the ligature they can ligate it when they are ligating the round ligament and the vascular pedicles, and sometimes it is intraoperatively identifiable and sometimes it is quite difficult to identify intraoperatively and it is found postoperatively, as you said. Is there any grading system available for ureteric injuries?
yeah, so there is a AAST grading system available for ureteric injuries as well, again from grade 1 to grade 5. Grade 1 is a hematoma or a minor injury to the ureter. Grade 2 is when less than 50% of the laceration involving less than 50% of circumference. Grade 3 is laceration involving more than 50% of the circumference. Grade 4 is complete transection, but the bridging is less than 2 centimeter. And grade 5 is complete transection with a separation of more than 2 centimeter.
Okay, good. So what are you going to do for this patient?
For this patient, she's postoperative day 1. So my concerns will be whether to do an early repair or a late repair. So that will be guided by the hemodynamic stability. Whether the patient is stable or not. I will start her on antibiotics, assess her situation. If she is stable, I'll involve the the previous operating surgeon and also the patient in the discussion. The principles of repair are, if the patient is stable, we can do the repair within 1 week of the ureteric injury. But if it is more than 1 week, then it is better to wait until the inflammation settles down. So it will be like 2 to 3 months time. If the patient is unstable, the best option is to divert the urine with a nephrostomy and then doing a delayed repair after 2 to 3 months. So in this situation, I believe if the patient is stable and we can say that the injury to the ureter is at the pelvic brim, I will involve the operating surgeon and the patient in the discussion, bearing in the background of my mind that this could turn out to be a medical legal case later. So I will involve both of them in my discussion and offer them the option of an early repair of the ureteric injury. So if they agree to an early repair, then I will arrange for the repair in the theater. So I'll make sure that the patient is aware of the options. One, when I do a retrograde pyelogram, if the dye goes into the ureter, I can try for a stenting. Very unlikely in this case because I can see that there was no contrast coming to the lower ureter. So I'll inform her that if possible, we'll put a stent. If not, then we have to explore and see. If it is like a very big defect, then we can try for a ureterostomy if the defect is less than 2 centimeter, but it might be a difficult option, the lower ureter. I had to consent her, I had to make her aware that if that gap cannot be bridged, then the option is to go for a psoas hitch, which might involve surgery on the bladder. So the patient should be informed beforehand. For that reason, I had to know what was her bladder functions beforehand, whether she had any lower urinary tract symptoms before, the capacity of her bladder before the procedure. From the CT scan, I can see that her bladder capacity, even though it is collapsed, looks almost like a normal bladder. So I'll tell her that it might involve a surgery to the bladder. And if it is, it's very unlikely that a Bubari's flap reconstruction is needed in this case because it's very low down the ureter. But I'll take the consent for that one as well because we never know. Only during the intraoperative procedure we know about the whether the tissue is viable, the ureteric tissue is viable or not, even though the contrast can come down up to the pelvic brim. So that will be my counseling for the patient and the surgeon who has operated. And afterwards, I'll take the consent for all these procedures, make arrangements for adequate blood available, and will take her to theater. If there is someone available in my team who is an expert in this field of ureteric injuries, I'll ask their help as well. And the approach will be to start with a cystoscopy to see if there is efflux of urine from the injured left ureter. If there is no efflux, then I can do a retrograde pyelogram and see if the dye is going up to the upper ureter. If it is going up, then I can try a gentle attempt at insertion of a guide wire and making sure that it is not going out of the ureter. If it is going into the kidney and if it is placed exactly in the pelvic calyceal system, I can try a stent in that case. Very unlikely in this case because I can see that the contrast was not coming down. If there is no efflux and if the retrograde pyelogram shows that there is no contrast is not going into the upper ureter, then we have to go for a repair of the procedure, repair of the ureteric injury. I think because of the collection, presence of drain and the previous surgery, the best option is to go for a open surgery in this case. The principle involved are to see, so once we open the abdomen, the principles involved are to assess the location of the injury, the length of the injury ureter, the presence of devitalized segment of the ureter, and to see if it is possible to do a end-to-end procedure like a ureterostomy. If a ureterostomy is possible, then the principle is again a adequate spatulation of the ureter, and then removal of all the devitalized segment of the ureter, and the anastomosis should be tension-free and should be done with should be done with other absorbable switches 4 or 5 over a stent. If a ureterostomy cannot be done, then for a lower ureteric injury, the best option is to go for a psoas hitch. Most of the time, the bladder can be mobilized up to the level of the psoas. The principle is again to, if needed, very unlikely, but if needed, we can release the contralateral superior vesical pedicle so that we can mobilize the bladder much more easily. The principle is again doing an anastomosis of the ureter to the mobilized bladder and fixing the bladder to the psoas with a non-absorbable suture, making sure that the genitofemoral nerve is not injured. And then the anastomosis of the ureter to the bladder is done in a non-refluxing fashion with non-absorbable sutures over a stent. If the injury is severe and it cannot be bridged with a psoas hitch, then the option is to have a Bubari's flap, which is a broad-based flap based on the anterior wall of the bladder. The principle is again taking an adequate flap, making sure that the bladder has got capacity to do a Bubari flap. We should maintain the ratio of 4:1 regarding the base of the Bubari flap and the tip where it is anastomosed to the ureter. And it is tubularized and anastomosed to the rest of the functioning ureter. And it is also done over a stent. If these things are not sufficient, I think a psoas hitch will be fine for this type of injury. Maybe we have to go up to the Bubari flap if there are a lot of devitalized ureter. But the other options, if these things are not working, are ureterostomy. And I have also heard about ileal ureter transposition if there is complete loss of the ureter. So that will be my approach initially for this patient. And after the procedure, I'll keep the catheter for 2 weeks to prevent any reflux into the kidneys. And also we'll keep the keep the stent for 3 to 4 weeks.
Okay, that's good. The one other option may not be which is used regularly, but just to keep in our armamentarium is auto transplantation. So in the extreme situation, not necessarily for this patient, if there is a complete ureter loss and many other reasons like multiple ureteric stricture or tuberculosis of the ureter very rare situations, autotransplantation has a role. Transureterostomy is to be considered a little bit as a very low priority because we don't want to jeopardize the opposite normal ureter, and also because of the transureterostomy, future access by retrograde ureteroscopy will become more challenging in case if the patient develops any stricture or stones, etc. What is the principle of maintaining the Bubari flap ratio, what you mentioned?
It's mainly for the vascularity of the flap. So we have to follow the principles of flap reconstruction, and it's also based on the vascularity of the bladder wall. So it has been found out that if we for the Bubari flap to have adequate perfusion, we have to maintain the 4:1 ratio of the ureteric length that is bridged.
Yes. So also it depends upon the capacity of the bladder, and Bubari flaps have been used to bridge the ureter even up to pelvic junction. But usually it's quite easy to bridge mid-ureter and lower part of upper ureter. Okay, so this patient had an uneven full Bubari flap surgery. You are quite happy with the flap and vasculature. You kept a drain. The drain was removed in say 24 to 48 hours. There is stent in situ. So how are you going to arrange the post-op follow-up?
So the post-op follow-up will be another retrograde study. So I'll tell the patient that we have to confirm the confirm that there is no extravasation of the contrast. So in theater under fluoroscopy, before removing, so we'll remove, put a guide wire, remove the stent, then do a retrograde study and make sure that the contour of the pelvis, the ureter, the reconstructed Bubari flap are all remaining in alignment, and there is no leak of urine. And if there is no leak of urine, contrast, there is no leak of contrast, there is no stricture, then we can remove the stent and there is no need for stent reinsertion. So the principle is going for a retrograde pilogram, making sure that the anatomy is acceptable, and then removing the stent.
Okay. Since you're doing a Bubari flap, it will be a kind of a reflexive type of anastomosis, and especially the Bubari flap can be easily delineated by a micturating cystourethrogram itself. So it is not always necessary to put the patient to anesthesia again and do a cystogram and retrograde studies. Outpatient in radiology suite, micturating cystourethrogram by filling the bladder. Patient may have had a catheter already, so use the same catheter to fill the bladder, and when you do a micturating study, that will give you an idea about the intactness of the bladder, and the Bubari flap will be nicely delineated, and usually the urine trickle into the lower ureter also. So there is not necessary to do another anesthesia procedure always. How are you going to make other follow-up arrangements?
The further follow-up will be to review her initially at 3 months' time, to mainly to make sure that her urea and electrolytes are remaining stable. She's recovering well from the surgery and she's asymptomatic. This will be followed by an ultrasound scan at 6 months' time to make sure that we can expect some amount of hydronephrosis because of the refluxing anastomosis, but making sure that there is no severe hydronephrosis as to suggest a stricture of the ureter at the anastomotic site. And will be followed up for 1 more year and make sure that she's not developing any more complications of the reflux or obstruction, and there's no further deterioration of the renal function. I'm unsure about whether there is a role for DMSA in this one, but I believe there is no role as long as she's remaining asymptomatic and her bloods are remaining stable.
Very good. I just want to clarify, you can make non-refluxing ureteral reimplantation into Bubari flap, but micturating cystourethrogram is enough to delineate the anastomotic intactness. Okay? Good. 2 things before we complete. We are very thankful for the radiopedia.org, a very nice website which gives excellent pictures on various urological manifestations, and it's so magnanimous that they are allowing us to use that in our teaching program. I'll be happy if the trainees can register and support radiopedia.org. They have got a wonderful collection of radiological images. The other thing is, trainees who are seeing this program in YouTube, you will be seeing various other informations, like for example staging of ureteral injury, grading of renal injury in your screens. But unfortunately for the trainee who is presenting, he is doing it by heart, out of his preparation. So my real thanks to the trainee who has made a wonderful presentation. To improve the quality of the recording, we are adding appropriate tables and informations for the people who are revising it as using it as a revision tool. Any other questions you have before we complete?
No, it was really comprehensive. Thank you so much. I mean, it helped me, even though I knew the theory, it helped me to organize the approach to a patient in a real life. Thank you so much for that.
Thank you very much. In the next episode, we will be discussing the other urological injuries like bladder injury, penile injury, and testicular injury. Hereby we announce class dismiss.